Hi all, in this video I'm going to explain in detail about spondylolisthesis. Coming to the introduction, spondylolisthesis is derived from the Greek word spondylos or spondylo, which means spine, and olistin or listhesis means to slip or slide down or a slippery path. And Herbinos in 1782, who was a Belgian obstetrician, noted a bony prominence in front of the sacrum that causes the problems in delivery. And Herbinos was credited with first having described this condition known as spondylolisthesis. And the term spondylolisthesis was first coined by Killian in 1854. And so in Greek, is already I have mentioned. In Greek, it is known as spondylo means spine, and listhesis means to slip or slide down a slippery path. And coming to the definition, so it is defined as the slipping forward of one vertebrae over the next lower vertebrae. So this is the spondylolisthesis definition. So it commonly occurs at L4 to L5 and L5 to S1 junctions. So it most commonly occurs at the lumbosacral junctions as well as L4 L5 junction. Spondylolisthesis is the most common cause of lower back pain in childhood. So before going to the condition in detail, so I would like to explain in brief about the various similar terminologies that is affecting the vertebra. So first condition is known as your spondylolysis. So spondylolysis is a pars interarticularis defect. And next condition is your spondyloptosis. So spondyloptosis is used to describe as a fall of L5 vertebra into the pelvis and lie anterior to the sacrum. Next condition is spondylitis. So it is a term used to describe several conditions that causes swelling and inflammation in the joints and vertebrae of the spine. So intervertebral joints of the spine. So mainly itis means inflammation. So as you know, itis means inflammation of your spondylitis means inflammation of the joints and vertebrae of your spine. Next condition is spondylosis. So spondylosis is an umbrella term used to describe the pain from degenerative conditions of spine. So this spondylosis is known as your osteoarthritis of the vertebra. So these are degenerative conditions that affect your both your cervical as well as your lumbar. So that is known as cervical spondylosis and lumbar spondylosis. So coming to the relevant structures. So these are the relevant structure, vertebral body and your neural arch. And it includes your pedicle, transverse process, lamina, prolamina, and so your spinous process and all. And the superior articular facet, inferior articular facets. So this is the superior articular facet, this is the inferior articular facets. So this is all about the anatomy structures of your vertebra. So coming to the particular structure that is known as pars interarticularis. So this is a part of a vertebra located between the inferior and superior articular process of the facet joint. So this is a specific structure that is present in between the inferior and superior articular process. And the Scottish dog sign, which I will be explaining in detail in the investigation part of this condition. So this is the pars interarticularis defect, and this is the spondylosis and the spondylolisthesis. So spondylolisthesis, slipping of one superior vertebra over the another inferior or lowermost vertebra. So coming to the classification, there are so many classifications, out of which the most common classification include your Wills, Newman, and Macnam classification that is based on the location of defect on the posterior element that allows listhesis. And the second classification is Meyerding's classification that is mainly a radiological classification that is based on the percentage of slip in the lateral radiograph, that is your X-ray. And Marchetti and Bartolozzi classification that is primarily based on the etiology, that is your developmental or acute type. So these are the three classifications based on the different structures. So Wills, Newman, and Macnam classification, Meyerding's classification, Marchetti and Bartolozzi classification. So first classification, that is your Wills, Macnam, and Newman classification. So they divided into different varieties. First one is your dysplastic type. Second one is ischemic or true type. Third type is your degenerative type. Fourth is traumatic type. Fifth one is pathological type. So this is the description about different types. So first type is your congenital. So that may occur as a result of dysplastic abnormalities. And second type is ischemic, and they have been further classified into three subtypes. That is A, ischemic type A, that is the lytic or stress fracture. Ischemic type subtype B, that is a heel fracture, elongated or intact. And ischemic type subtype C, that is your acute high energy fracture. And third type is your degenerative, that is your that occurs as segmental instability. And 4, that is your traumatic. That is mainly because of the fracture of hook other than your pars intra-articularis. And 5th type is your pathological. That may be because of some any underlying pathology of your spine. And 6th one is your iatrogenic. That is due to surgical excision of your posterior elements. So this is the Bills, Newman, and McNam classification in the 1976. So first classification, dysplasty, that is congenital abnormalities of upper sacrum or the arch of L5. This permits the listhesis to occur. Second type is ischemic, that is true type. This lesion occurs in the pars and is the most common variety. And this ischemic type is more common in children and rarely seen before 8 years. So at adolescent growth, sport, sudden increase in activity, gymnastics, carrying heavy bags, etc., may lead to fatigue or stress fracture of the pars, which may give rise to the slippage. So the subtypes include lytic fatigue fracture of the pars in children, elongated but intact pairs, acute fracture of the pars due to trauma. So third type is your degenerative. So this is due to long-standing intersegmental instability. Here the pars intra-articularis is intact, but the facet joints degenerate and allow the forward slippage or anterior slippage. And fourth type is traumatic. This is due to fracture in other areas of the body, bony hook rather than the pars intra-articularis. Fifth type is pathological. This is a generalized or localized bony disease in this variety. So there is some generalized or localized bony disease in this variety. That is the pathological. It occurs as a result of some pathology of your spine. So next classification is Marchetti and Bartolozzi classification. So based on the etiology. So it has been classified into two types, developmental type and acute type. So developmental type is again classified into high dysplastic and low dysplastic. High dysplastic with lysis or high dysplastic with elongation is the subtype, and low dysplastic with lysis and low dysplastic with elongation is the subtype. And coming to the acute type, so that includes your subtypes, includes your traumatic, post-surgery, pathological, and degenerative. These all are based on the etiology or the cause. So traumatic may be because of your acute fracture or stress fracture, post surgery because of your direct surgery or indirect surgery, and pathological, the cause may be because of the local pathological conditions or systemic pathological conditions, and degenerative may be because of your primary or secondary causes. So these are the Marchetti and Bartolozzi classification based on the etiology. So coming to the etiology, so it may be either due to the congenital, that is maldevelopment of neural arch of the fifth lumbar vertebrae, ischemic cause, degeneration, old age due to ligamentous instability and degeneration of the facetal joints, or it may be occurring due to the trauma or any pathology in the pars intra-articularis, that is the any pars intra-articularis defect, and weakness of supporting structures. So coming to the pathology, so pathology occurs a weakness of pars intra-articularis of the lamina of the vertebra causes the slippage. There is a fibrous defect in the lamina between the superior and inferior articular process. Failure of bony fusion between the two parts result in these fibrous defects, and presence of lumbar lordosis and upright posture leads to an increased stress concentration at the pars intra-articularis. Flexion overload, unbalance, and forced rotation in flexion may result in failure of neural arch. And minor trauma could cause a separation of these two parts, vertebral bodies with pedicle and superior articular process, and the transverse process slips forward and carrying vertebral column and leaving behind the inferior articular process and the spinous process of the fifth lumbar vertebrae. So coming to the clinical features, the most important clinical feature includes your low back ache or low back pain and pain radiating down to the thigh. That is mainly because of an osteophytes at the posterior joints, and exaggerated lumbar lordosis, and step-like deformity while palpation, nerve growth limitation of movements, paraspinal muscle spasm, and there will be tight hamstrings, cauda-equina syndromes, and in some cases the patient will be also having a weak abdomen muscle weakness. So this is a step-like deformity or step sign which can be able to find during the palpation of the vertebra. So there we can see that there can be a step-like deformity present over the patient's back, and the abdomen will be in a protruded manner. So coming to the clinical features, like in different conditions, like in true spondylolisthesis, they will be having asymptomatic or low back pain, history of trauma present in 50%, common history of injury in adults and children. The deformities include increased lumbar lordosis, palpable step deformity at the L5-S1 junction, torso is short, abdomen is protruded forward, transverse furrow at L5, sacrum is vertical, buttocks are flat, and hamstring tightness are present. L4 spinous process prominently felt, scoliosis in 13% can be seen. And L5 nerve root may or may not be involved, but the chance of nerve compression is rare. And coming to the congenital type, pain will be over your low back, buttocks, feet, toes, thighs and legs. That means the radiating pain can be seen in this condition. Congenital types: scoliosis, pelvic viadal present, buttocks are flat, stiffness of spine may be present, cannot bend beyond the lower thigh. So maybe the L5 or S1 nerve root is involved. And coming to the degenerative, this is known as pseudo-spondylolisthesis. Intermediate symptoms and is common in the elderly patients, 5 times more common in women, and affects 4 to 10% of the populations. And deformity mainly your pain in the back, buttock, or thigh. And neurological condition maybe the L5 may occur, that too rare. Neurological claudication may be present, and L3 to L4 nerve roots are commonly affected. So coming to the investigation, the first investigation is your X-ray. So we can see the stepping forward of one vertebra over the another in the X-ray or radio X-ray findings. So based on the X-ray findings, we will be dividing or we will be classifying the spondylolisthesis. So that into different grades. So grade 1 is up to 25% of slip, and grade 2 that is up to 50% of the slip, and grade 3 that is up to 75% of slip or 3/4 or the length. So this is grade 4 actually. So grade 4 more than 75% of the slip. So grade 1 less than 25, grade 2 means up to 50%, and grade 3 means up to 75%, and grade 4 means more than 75%. So this is the Madding's classification or Madding's grading for your degree of slippage of your spondylolisthesis condition. This is the radiological classification, that is your Madding's grading. So next investigative finding is your sacral inclination. So this is measured as an angle formed by the posterior sacral border with the vertical border. So this is how you will be classifying the X and Y. So this is how we will be finding the slippage, like percentage of slippage, and by calculating the degree of sacral inclination by measuring the angle between the posterior sacral border and the vertical line perpendicular to the floor. So this is how you will be measuring the sacral inclination and the percentage of slippage. So coming to the third investigative finding, that is overall degree of lumbar lordosis. So this is measured from the top of T12 to the top of L5, both L5 and S1, lumbosacral junction. This can be accurately determined from the lateral radiograph, lateral view of your X-ray. And you can also use the CT scan in order to find any fracture issues or any other investigative finding in detail, comparing with your X-ray. And coming to the MRI, so which is the gold standard investigative finding, and you can able to show significant in neural foramen shape, and it can also detect compression of the spinal cord, or the disc prolapse can also be seen in these MRI films. So you can see here there is a compression over the particular region, and in this MRI film you can able to see there is a slippage of L5 vertebrae. So L4, L5 spondylolisthesis can be seen, which is compressing the spine. The disc is getting compressing the spinal cord. So L4, L5 spondylolisthesis because of the degenerative disc, which is compressing your spinal cord. So this is the region of or area of compression. So coming to the tear sign, Scottish tear sign or dog sign. So Scottish dog sign, you can see here. This is the neck, that is your pars intraarticularis, and eye is your pedicle, and nose is your transverse process, ear is your superior articular facet, forelegs is your inferior articular facet, and hind legs is your spinous process. So this is the Scottish dog sign. So this is Scottish dog sign, which is clearly seen in your radiological findings. So coming to the management, so different methods of conservative management are seen in different conditions, or like different severities. Asymptomatic cases means you can give the postural correction or ergonomic advices, that is the elimination of stressful occupation, and to avoid certain special sports activities. So mainly your corrective techniques. And mild to moderate cases means we can elevate the anxiety. We can provide analgesics and muscle relaxants. Deep heat modalities like short wave diathermy and other deep heat modalities can be advised, and exercises. In severe cases, rest, non-steroidal anti-inflammatory drugs, gradual exercises to strengthen the trunk and hamstring muscles are also advised. Too much of severe cases, we may go for surgical management. So coming to the first conservative, that is bracing. Bracing forms an important part of conservative management. Anti-lordotic total contact thoraco-lumbosacral molded brace is fabricated in the current position of lordosis. The measurement of slip percentage, sacral inclination, and the degree of lumbar lordosis are taken into consideration while fabricating the brace. The braces has to be worn continuously. Bell et al. 1988 has reported successful results of conservative treatment but it needed brace for an average period of 24 months. So this is the brace which is given for this particular condition, that is your spondylolisthesis. Coming to the surgical management, the indication for your surgery includes your failure of conservative management, signs of nerve root compression, progressive slippage more than 30%, persistent pain in the back, thigh, or sciatica. So these are the indications for surgery. There are different surgeries which we are going to look into. So first surgery is your posterolateral fusion. This is the best method of fusing the slipped vertebra because it preserves the supporting soft tissues and has a high rate of fusion. That is the posterolateral fusion. And second is your posterior fusion. In this method, post-operative and additional slip is frequent until the fusion is solid. This also has a high rate of pseudoarthritis and has to be done with intertransverse fusion. So next is your laminectomy. This mainly helps to relieve the neurological deficits and has to be followed with your posterolateral fusion. And anterior interbody fusions. This is indicated for subtotal spondylolisthesis and is a risky and difficult procedure with doubtful efficacy. So next is your methods of fusion and stabilization. The fusion is achieved in spondylolisthesis by putting autologous cancellous bone graft and hair shield, a rectangle frame, or Steffe plate and screws help often stabilizations. So these are the different surgical methods. So that includes your posterior fusion, posterolateral fusion, anterior interbody fusion, laminectomy, and your stabilization by different plates and frames. So coming to the management, physiotherapy management. So mainly deep heating, you can give your short wave diathermy and other modalities. Next is your postural correction, deformity corrections, stretching of hamstrings, and different exercises for your strengthening as well as your stretching. So deep heating modality, it is effective in providing the relief of pain. Postural correction, correction of posture at rest as well as work during work plays a key role. Maintenance of flexion attitude is important. So correction of deformity by corrective exercises. Exercises to improve relaxation and general mobility of spine are initiated first. Obliteration of the exaggerated lumbar lordosis in supine lying is taught by active posterior pelvic tilt and its maintenance. Strong abdominal exercises are taught, maximal effort being placed over the lumbar spine. So these are the exercises to achieve the active correction of your lumbar lordosis. So this is the exaggerated lumbar lordosis. So we will be actively correcting, we will be explaining the patient to actively correct with the using your lower abdomen muscles. So this is the pelvic correction, tilting correction exercises. So we need to facilitate the flexor aspect. So flexion movement should be facilitated. So this is how you will be forward bending of your trunk in the chair. So this will facilitate your abdomen muscles. So armchair sitting with the lower back resting against the back of the chair. Gradual forward bending of the trunk at the lumbar region with strong abdominal contraction, holding the breath. And regular periods of prone lying and hamstring stretching. These are necessary to control the advancement of lordotic tendency. So exercises. So it improves the relaxation and general mobility of the spine in order to strengthen the abdominal muscles and actively posterior tilting taught to the patient. And armchair sitting with the lower back at the back of the. These are the exercises which we already seen here. This is the pelvic tilting as well as this is the maintaining the abdominal muscle contraction, flexion attitude, maintaining the flexion attitude of the spine. So this is the pelvic tilt exercises, and this is the abdominal contraction, that is sit up with the knee in flexion, and this is the knee to chest, single knee to chest and double knee to chest in order to stretch your paraspinal muscles. So we'll be using this knee to chest exercises and seated reach to toes. So this is used to stretch your hamstring muscles, and forward crouch to stretch the iliofemoral ligament, and seated flexion in order to strengthen your abdominal muscles, and squatting. So all these exercises are given in this spondylolisthesis. So the exercises to avoid includes twisting or bending activities, high impact activities, and that may create a load, excessive load over your spine, and weight lifting. And same exercise only, pelvic tilt, dead bug exercise, quadruped, but that is your bird dog exercise, piriformis stretching, partial curl, all fours to heel sit. So these are the common exercises which we will be prescribing in spondylolisthesis conditions. And coming to the surgical management. So during immobilization, we will be giving the deep breathing exercises, arm movements, ankle and foot, ankle toe movements, assisted knee movements, hip flexion when given should not be beyond the 60 degrees. So isometric to your muscles, including your lower back muscles as well as your lower leg muscles. So coming to the mobilization phase, A POP jacket is applied by the second week of operation. The jacket continues for a very long time, sometimes even up to 6 months or till the fusion is evident. Therefore, total mobilization with the jacket should be instituted immediately. Educating and guiding the patient to perform functional activities forms an important part of the management so that he does his activities of daily life and goes back to work. When the jacket is removed, gradual mobilization of the spine is initiated as described in the conservative management section and progress till total functional independence is achieved. It may take up to 7 to 8 months to regain the full function of your spine after your surgery. So these are the different exercises which will be given to the spondylolisthesis conditions. Mainly your range of motion and stretching exercises. So mainly range of motion for your lumbar flexion and your pelvic tilt exercises, quadruped lift, that is your bird dog exercises, and double leg hold exercises. So partial sit-ups. So these are the exercises which may be helpful for improving the strength of your abdominal muscles. The maintaining of the flexion attitude is very important in spondylolisthesis condition. And this is your posture and body mechanics. So that includes your postural correction. We will be educating the patient to use the proper lifting or proper sitting techniques or proper ergonomic advices we will be giving to the patient to for mainly that is your postural correction exercises. So how you need to lift your some weights from the ground. So you need to flex your knees. You need to bend your knees, then you need to go. So you need to maintain a straight spine and use a footstool or objects that need to be placed or retrieved from high locations, and use two people to lift the heavy or awkward objects rather than lifting by a single person of this particular condition who is having this particular condition. So these are the correct lifting techniques. These are the incorrect lifting techniques. That includes single-handedly taking a high weight, keeping something above your height by twisting motions. These are twisting motions. These are the things we need to avoid during this condition. Twisting, high impact activities, high bending activities, everything should be restricted, or these are the not proper lifting techniques. So this should be avoided. And correct sitting postures and incorrect sitting postures. So this is the proper, we will be giving the proper ergonomic and postural advices to the each clients who is having these particular conditions, and we will be using we will be advising to sit straight erectly and using some pillow, lumbar roll or cushion or any other pillows over the affected region. So this is the correct sitting posture, and twisting or bending sitting in a sofa and slouching or slumping. So these are the incorrect postures, so we should be avoided. So we need to advise the patient for or educate the patient and advise the proper posture. And this is the one of the evidence-based practice. So this is the recent rehabilitation protocol for spondylolisthesis patients. So this was published in the year 2023, just 3 to 4 months back. It was published in June, and it was published in the Journal of Spinal Research and Spinal Surgery. And this was published by Majidur Rahman. So this is he is the primary author. So this is the topic, rehabilitation protocol for a spondylolisthesis patient. So a treatment protocol, and this is the chart of the different conditions or the protocol which they had incorporated to treat the spondylolisthesis patients. So in order to reduce the pain, they will be giving the lumbar spine flexion exercises, moist heat, hot packs, and TENS. And for the faulty body posture, in order to correct the posture, they are educating the patient and they are giving the postural awareness, instruction for the proper lifting technique, and using a lumbosacral brace during traveling and exertion. And next goal is to reduce the range of motion. They'll be giving your lumbar flexion exercises and passive stretching, and tight hip flexors, hamstring piriformis, and thoracolumbar fascia. They had given passive stretching through those stretches. And pelvic floor and abdominal muscle weakness, they had given strengthening exercise to the pelvic floor and abdominal muscles. Abdomen and lower back muscles strengthening, that is isometric or isotonic exercise, has been given to those muscles. Hypermobile of the thoracic spine, they had given the Maitland's rhythmical oscillatory central posterior to anterior glides. And lumbar instability, they had given lumbar stabilization exercises twice a day, every day, 10 repetitions of each exercises, and specific stabilization exercises are also taught to the patient. And abnormal spinal alignment, they had given the lumbar traction, supine and prone lumbar traction has been given. And in order to correct the posterior pelvic tilt, they had given the posterior pelvic tilting exercises. And for the paraspinal muscle spasm, they had given the myofascial releases. So this is the different impairments and the various physiotherapy treatment for each impairments. So this was the recent evidence-based practice which was published in the year 2023 June. So this is all about the conditions, spondylolisthesis condition and its physiotherapy management as well as the other management too. So thank you for watching this video. Please do share this video to your physio friends and community. Thank you.